Hello, everyone. This is Dr. Siddharth Tambar. Welcome to our webinar today, talking about regenerative medicine treatments. Before I get started, if somebody in the audience could just raise your hand or let me know if you can hear me loud and clear and if you can see the screen as well. Great. Thank you very much. Thank you. I already see some questions starting to come on. If, as I'm discussing for the next 30 minutes or so, please send in your questions or thoughts as we're going through this, and I'll make sure that we answer them as we go along. So here's what you'll get from this webinar today. You'll learn about the best available treatments for arthritis, tendinitis, injuries and back pain that do not require surgery. You'll also learn about what is legitimate in the field of regenerative medicine and what is not. And you'll also learn about how to choose the best physicians and clinics for your regenerative medicine treatment. And again, as we're going through, if you have any questions after we're done, you can always reach us at chicagoarthritis.com. In addition, in the chat section, you should have a list of 3 different ways if you need to contact us to either schedule, or if you have questions in the future, you can call us, email us, or reach us via our scheduling app. So the big question is, what would you do if your pain was controlled? How would your life improve? What exercise would you restart? And what activities with family and friends would you participate in again? So just a bit about who I am before we get started. My name is Siddharth Tambar, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in regenerative medicine, and in image-guided treatment procedures. In practice since 2008, involved in regenerative medicine since 2008, and part of the Regenerative Network, which is the largest network of affiliated physicians that share regenerative medicine best practices and techniques, and been in that network since 2012. So my personal journey through regenerative medicine really starts with my own shoulder. I used to play a lot of tennis when I was in high school and never really had problems at that time. In my medical training, as I started to learn about diagnostic musculoskeletal ultrasound, I noticed that I had some mild rotator cuff changes in my right shoulder. And as I got older and restarted playing tennis and other physical activities, I then started to develop some shoulder issues. And that then got me thinking about tendon and ligament injuries in a different way than what I had been taught, which then got me interested in what are some other treatment options for treating musculoskeletal conditions that are really helpful for the tissue long-term, which is what first got me interested in platelet-rich plasma back in 2008, which then led me to an interest in bone marrow stem cells a couple of years later. So traditional care for either joints, tendons, back issues is very much about masking the pain with pain medications or injections that really just cover the pain and just essentially waiting for surgery. The comparison to, let's say, in other aspects of medicine, let's say in diabetes or blood pressure, would be to wait until you've had your first heart attack or stroke. Nobody would do that in those conditions. They would start to treat beforehand. And we need to have that same sort of proactive approach when it comes to treating our joints and tendons as well. So problems with traditional care include pain medications don't fix the problem. They just mask the problem. They do have side effects. Traditional injections, such as steroid injections, nerve blocks, radiofrequency ablation, they can help with pain, but again, they're not really healthy for the tissue long-term. Steroid injections, if you do them too often, can eventually cause damage to the tissue. Nerve blocks, radiofrequency ablation, too often will eventually weaken the nerve, which can then actually cause muscle weakness and then cause other issues as well. Surgery has a role, right? There's certain conditions that just need surgery, but the routine surgeries that we do for a lot of musculoskeletal issues have issues. To begin with, surgery is higher risk than needle-based procedures. A lot of traditional surgeries that are done, let's say knee arthroscopy or shoulder arthroscopy, if you already have an arthritic component there, doing the surgery does not lead to a better outcome long-term. In fact, it leads to more instability and is not actually better than, let's say, just physical therapy. And so for those of us involved in regenerative medicine at a very deep level, feel that 80% of what's being done by surgery currently should be done by regenerative medicine, in the same way that at one time, all cardiac issues were handled with open heart surgery, and now only 5% of cardiac issues actually get to open heart surgery. So in searching for better options, we need options that are lower risk and avoid serious side effects. They should address the source of the problem, which is instability and inflammation. And we'll talk about that. And if we can improve the actual cause of the problem, we'll give you a longer term and better improvement as well. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the process where we utilize your body's own cells to treat your arthritis, tendinitis, injuries, and back pain. So the normal healing process, let's take something as simple as a cut on your finger. What happens is that you have platelets that infiltrate the area. They first stop the bleeding. They then release growth factors. Those growth factors then lead to stimulating your local stem cells, which then starts a normal healing process for that tissue that's been damaged. That includes initial inflammation, that includes bringing other cells and eventually rebuilding tissue. So that works very well when you have good blood supply in tissue. It doesn't work so well in tissue that may be robust, like your joint, your cartilage, your meniscus, your labrum, your tendons, your ligaments that are robust but that lack a good blood supply. So regenerative medicine is a process where we take those same cells, your platelets and your bone marrow stem cells, and we then, under high-level image guidance, inject that into the tissue that's been damaged in an attempt to actually start that normal healing process. So what are we doing here? We're essentially treating instability. That means the ligaments, the soft tissue structures that have been injured over time that are causing instability, that is putting stress on the joint. We're strengthening that tissue to help reduce the stress on the joint. We're then also reducing the chronic inflammation that you see in a damaged joint or tendon. And a damaged joint or tendon, what you have are cartilage cells, joint cells, tendon cells that are no longer functioning very well. They're not pumping out the right kind of enzymes and proteins. So what you get is a joint or a tendon that is more inflamed chronically. By getting those cells to start functioning better, you have less inflammation. We do all this in a way that is safer than surgery and that is effective for most musculoskeletal conditions. So how does regenerative medicine work? We're optimizing your tissue that's been damaged. We're improving the strength and stability of ligaments, tendons, and other soft tissue structures to improve stability. We're reducing chronic inflammation, and we're also improving your overall neuromuscular health. So this is a busy slide, but what makes a regenerative medicine expert? There's a lot. The first is your physician should be a musculoskeletal expert. And what that means is if your doctor is treating somebody's blood pressure and they're low testosterone in one room and then running to treat your knee, that's not an expert. Medicine works by being so focused on what you're doing, you become they should be a non-surgical musculoskeletal expert. Our surgical colleagues are very good at treating things with surgery and treating things with by removing tissue or putting in hardware. The thing is that that's not very helpful for most musculoskeletal issues. And our surgical colleagues don't have the same training when it comes to image guidance, when it comes to these kind of procedures. And the reality is that with these kind of treatments, you have to have a very high level of image guidance expertise. And so your physician should never be doing these treatments just based on feeling the joint or the area. They should be using X-ray and ultrasound guidance, because when it comes to injecting your cells, you have to be at a less than 1 millimeter by 1 millimeter precision. You can't do that blindly. Your physician should understand how inflammation works. I have a lot of pain management colleagues who may say that they offer these kind of procedures, but the reality is that they're offering steroid injections left and right. And the problem with that is that the way you treat inflammation should not be steroid injections left and right. That is very short term. Or they may be utilizing treatments like nerve blocks and radiofrequency ablation that really actually makes the tissue worse long term. And that kind of lack of understanding of how to properly treat inflammation, that you want acute inflammation, you don't want chronic inflammation, and that lack of understanding of where biologic treatments fit, meaning when to use platelets, when to use bone marrow, not as a last case scenario, not after you failed all the nerve blocks and the steroid injections and arthroscopic surgeries. You should really be using these up front. That's a better option. And also understanding that your treatment should not be a one-size-fits-all approach. Your treatment should be tailored to you. And I'll kind of give you more examples of that later on. They should understand the concept of prolotherapy and how to treat instability. If you're only treating the joint, you're not treating all the soft tissue elements, you're not going to get the right kind of outcome. A lot of folks who do these treatments don't have that understanding, unfortunately, and are shortchanging you in your results. In addition, they should be transparent regarding your results and your candidacy for treatment. They should not be just doing this off the cuff. They should understand what makes you a good candidate versus what makes you a poor candidate. You should follow your results long-term. They should not just be doing a procedure, not seeing you again. And they should be able to guide you through the process. I have colleagues that will tell you that they dabble in these treatments. They don't have a lot of experience. They're not exactly sure how things work. The reality is that while these treatments are newer, they're not new. There's experience that in these kind of treatments that goes back to literally the mid 1990s. And if you're experiencing this, these treatments are not new. You should have the right experience and understanding of this. Other common questions that I get asked, is this legal? Answer is yes. There are very strict guidelines from the FDA. As long as you follow those guidelines, this is legal. And those guidelines are, you should be treating musculoskeletal issues only. If you're trying to treat Parkinson's and cardiac issues, that's not legal per the FDA. Your cells, when they're taken out, they should be re-injected the same day. They cannot be saved and stored or cultured in the United States. And then lastly, you should be using your own cells, not somebody else's cells. Important, because that's where all the data is. That's where all the safety data, that's where all the efficacy data is as well. Another common question that you'll hear, unfortunately, from people who've been to other clinics is that they've been told that if they're older, they should be using somebody else's cells. That is not accurate. For the vast majority of orthopedic conditions, there's good evidence that using your own live cells is effective. In addition, is there an age limit? No. For all the areas that we treat, spine, upper extremities, lower extremities, there is no limit. The one exception are hips, where if your age is over 65, you then become a more challenging candidate. What sort of doctor does these treatments? As I've mentioned, physician focus on musculoskeletal treatments, physician focus on non-surgical treatments, not surgery, and a person who's a proper regenerative medicine expert with all those things I mentioned. So can these treatments help if you've already had surgery? If you've had an arthroscopy, yes. However, if you've had the joint replaced, now you've got hardware, they've cut out the bone, that is now more of a managing a hardware issue. Unfortunately, that's more of a surgical issue. The one exception would be, let's say you have chronic knee pain, chronic hip pain, and you've already had a replacement, but it turns out your pain is coming from the back, right? That happens frequently. My general rules for orthopedic surgery is try to keep your own anatomy as much as possible. Avoid surgeries that are just cutting out tissue. Repairing tissue is one thing, but the vast majority of arthroscopies are really just cutting out tissue. And always consider a regen med treatment procedure if you've been recommended surgery. So we're going to talk about a few other key concepts here. Before we do, let me just take a look at some questions, start catching up here. Okay, so question, can you get regenerative medicine treatments can you start regen med treatments before the joint gets too degenerated earlier in the process rather than later in the process? Yeah, ideally you would get treated when you're at an early stage. The reality is that we treat people at all stages, and that includes folks who are at a more advanced stage, but clearly better off if we're treating you at an earlier stage. You have a much higher threshold for improvement. You'll get pain improvement, functional improvement, even if you're at a later stage. But for catching at an earlier stage, the hope is that can we reverse any damage if it's at an early stage? That is going to be hit or miss depending on the kind of problem that you have. But even more importantly is, can we prevent this from progressing? All right, and that is very possible if we catch this at an early stage. Somebody asking about treating a medial torn meniscus, must be for a knee after the scar tissue is formed. Yeah, look, we cannot, if you've had a torn meniscus and it's been a while and now it's scarred down, we can't replace the meniscus. What we can do, however, is improve the stability because there are ligaments attached to that meniscus. We can improve the stability by strengthening the ligaments over the knee. We can even strengthen the meniscus as well. So still very much a treatable issue. Okay, somebody asking, they've had, very physically active, a lot of running activities it looks like, wants to get back to that. They've got bone-on-bone arthritis, scheduled for a knee replacement. Yeah, I mean, look, bone marrow, stem cells, even in that case, if you've got advanced arthritis, can still give you a 65 to 70% on average improvement. That's even if you've got advanced arthritis. Whether or not you can get back to running a marathon, it depends on where you are, like what you're able to do right now. I think if you haven't run a marathon in 5 years, that's going to be hard to get back to realistically. On the other hand, if you can run 5Ks and 10Ks, and you've been able to do that, let's say 6 months ago, I think getting back to that is very realistically by using your own bone marrow. In terms of long-term effectiveness, when you look at bone marrow, the data that we have shows that you should get, on average, 5 years improvement before you need a repeat treatment or a refresher treatment, a booster treatment. What I tell people is if you've had chronic issues, think a little bit more conservatively, which means that if we treat you, hopefully you get to that 5+ year mark. But if you need, let's say, a platelet booster treatment beforehand, let's say after a couple of years, that'll kind of keep the effectiveness of that first treatment going as well. Talking about Synvisc, so same person asking about Synvisc for the knees. Synvisc is a very old treatment, the hyaluronic acid injections. These are called the gel injections. They were originally kind of presented, and physicians would present it as, hey, this is like a gel meant to give you more cushion in your joint. The reality is that that's not accurate. They were just longer lasting anti-inflammatory injections. They help for pain. They don't help for instability. They don't help longer term than 6 months for most people. They can help, like low risk option. When you look at gel injections versus platelet injections, platelet-rich plasma does better and gives longer term results as compared to gel injections. If you compare platelets to bone marrow gives longer term and better results longer term if you've got moderate to more advanced arthritis compared to platelets. So I think Synvisc and the gel injections are mild options. You know, they can help, but they're not as strong as what else we have. Another good question, somebody asking about neck issues. They've got a lot of crepitus or kind of cracking noises coming from their neck. Could it be due to loose ligaments? Possibly, right? Like when you think about all the tissues that are surrounding, let's say, the neck, you've got muscles, tendons, obviously a lot of peripheral nerves. You've got ligaments, you've got the facet joints, you've got myofascial tissues. That's basically the connective tissue that connects all this together as well. And so you have a lot of other structures there that could be involved as well. I think if your range of motion is reduced, or if you've got arthritic issues, if you've got some pain, certainly a treatable issue. I don't treat necks, I would refer you to a colleague, but certainly a treatable issue if required. Okay, let's keep on going. So stability is really the first key thing when it comes to regenerative medicine treatments. There's this concept in architecture called tensegrity. What it means is that if you take individual units that are relatively weak on their own, if you put them in close approximation to each other and compress them, you now have a stronger overall unit. In addition, this concept in medicine is called biotensegrity. And now that refers to your own tissue and cells. Prolotherapy is this idea that if you inject your own cells into your soft tissue supportive structures, you can strengthen and stabilize things even more. This concept is key because you have to treat all the different layers and this depth of treatment, and you will get progressive strengthening over time, which will then give you longer lasting improvement over time. So for folks who say that they're not going to get longer, so when your surgeon or your physician says you may not get longer term benefit from some of these treatments, it may be because they're only treating the joint. So as an example, this is a case of a lower back patient, 71-year-old man. He'd had prior lumbar surgery. He was still having pain, a very common issue that you see in patients who have lower back issues. We treated him originally with platelets, treating his ligaments, facet joints, muscles, and epidural space. He had partial benefit to begin with, 30%. We then escalated to using his own bone marrow because he did have prior surgery, trying to give him a better result, and treating all those same structures, ligaments, facet joints, muscles, and epidural space. He's now had a higher level of improvement, 75%, with improved function and longer lasting improvement as well. The key here is that you treat all those tissues. And so in the case of that individual who's saying that they've got knee arthritis, look, if you only inject cells into the knee joint, you'll get partial benefit. But if you treat the ligaments, the tendons, the meniscus, sometimes the bone if needed, you treat all these other structures, you'll get a better long-term result. Orthobiologics are the biologic cells and tissues that we inject into damaged orthopedic tissue. That includes your own blood platelets, your own bone marrow stem cells. Again, this uses your own normal healing process. Please use your own cells, not somebody else's. So we talked about how platelets are your first line cells that jump in after an injury. Again, utilizing inflammation, they work by stimulating your local stem cells. There's multiple different types of platelet preparations. The two main ones that we use are platelet-rich plasma. That's where we take a sample of blood from you, concentrate into a high concentration of platelets, and then re-inject that. Those platelets can be in various different concentration. We try to use very high concentration platelets for joints and tendons, and lower concentration of platelets for ligaments and nerves. In addition, you want to use platelets where you don't have the red blood cells. So the picture on the right, you have a platelet preparation that's amber or orange colored. That is platelets without red blood cells. And then you've got platelets on the right where they've got more red blood cells. The one with more red blood cells causes more inflammation. We don't want that for most tissues. For muscle tissues, that's actually helpful. But for other tissues, we prefer the ones without all the red blood cells. In addition, we also make a platelet preparation called platelet lysate, where we take your platelet-rich plasma, we crack open the platelets, and we just take the growth factors and inject that. That is better for nerve-related issues. So the key, the main takeaway point here is that your physician should have the dexterity and know-how of doing all this. Different level concentrations, different platelet preparations, different platelet concentrations for different issues. It should be very bespoke and tailored to your issue. If this is just a two test tube blood test tube draw and they're just kind of injecting you within 2 minutes, you're not getting a very personalized approach. This kind of lab prep will take at least an hour to 2 hours to do properly, to make everything properly. So this is an example of platelet treatment. This is a man who's got knee tendinitis. He's a 45-year-old man. He's a regular professional worker, but he happens to be he does a lot of cycling. Presented with left knee pain. He's got patellar tendinitis. He was referred to me by a sports medicine physician. The picture on the right is an ultrasound image of his patellar tendinitis. He had failed multiple non-surgical options, which is why he came to me. He ended up getting platelet-rich plasma treatment twice. The picture on the right is an ultrasound image where we've got the needle coming in, injecting directly into where the tissue's been chronically aggravated. He had 2 treatments, doing great, returned back to his full capacity. 3 years later, he now had a right knee hamstring strain. This is his other leg now. Again, PRP treatment and doing great. What I like about this example is platelets as a first-line option for a mild to moderate condition, for a soft tissue injury, as well as repeat treatments, giving someone even more benefit. And the fact that we then treated his other leg, again with platelets, and again, great response as well. Last kind of main orthobiologic you want to be aware of are stem cells. These are the main cells that drive tissue repair or recovery after an injury. Use your own cells. In the United States, the only bone marrow stem cells that are legally allowed are from your own bone, are the only stem cells legally allowed are from your own bone marrow. Fat stem cells not legally allowed in the US. All right. There is some evidence that fat stem cells work, but not legally allowed in the US, because the enzyme you need to break apart the fat to get to your stem cells is deemed to be unclear if it's safe. And that's why the FDA is concerned. But you can use fat or adipose for structural support. So we'll use that. We'll mix that with either platelets or bone marrow. We'll use that for rotator cuff injuries, for example. But really, bone marrow are your only legally allowed stem cells in the US. You may hear from other clinics where they're using amniotic or umbilical cord cells. There are no living cells in that. If they're telling you otherwise, that is inaccurate. If they're telling you that you should use those cells because you're too old, that is not accurate either. That's all a misunderstanding of the literature. You may hear about IV stem cells in other parts of the world. There's no proven benefit for orthopedic conditions. It may help with general inflammation, but again, not really recommended if you're treating orthopedic issues. Okay, so common questions that we hear when it comes to stem cell treatment outcomes. include, can we improve things if you've got more advanced arthritis, right? If you've got quote unquote bone-on-bone arthritis. I'll show you some examples where we can, but yes, we can. Can we improve how your images look? So if you've got advanced arthritis, I cannot get your joint to look like what it was when you were 20 years old. Now, if you have a tendon tear or ligament tear and it's less than 2 centimeters, yes, we can get that to look close to normal. I'll show you some examples of that. If you've got bone swelling where the bone is actually swollen and causing irritation in an arthritic joint, we treat that, we can get that to reverse as well. If you've got avascular necrosis, that's where there's damage in the bone causing the bone to die. We catch that at an early enough stage, again, we can treat that. So this term, can we treat bone-on-bone arthritis? Yes, because arthritis is a biologic condition, it's treatable with biologic treatments. In particular, if your range of motion is intact, function is still intact, good outcomes are still possible. That individual asking about, can we treat your knee? Yes, we absolutely can. The evidence for treating advanced knee arthritis is that we can still improve your outcomes by 65 to 70% on average. So yes, absolutely, we can still treat that. Yeah, some great questions coming in about, can we treat bone-on-bone knee arthritis? Yes, we can still treat that. The one caveat to advanced arthritis is that if you've got really advanced hip arthritis, that is much harder to treat. I generally will recommend that patients go for hip replacement in that case. But if we're catching your hip at an early enough stage, can still improve things for sure. I see another question asking about back treatments as well. Absolutely. Even if you've got an advanced level of issues, we can still definitely treat that. The most common things that we treat are knees and backs. And the outcomes for both of those are fairly good and consistent in terms of outcomes. And so, even if you've got disc bulges at multiple levels, that's still treatable. You want to try to avoid cutting out the discs as much as possible, like a microdiscectomy. May help temporarily, but realistically, as you start to cut out tissue, you're leaving the overall joint or area more unstable, and that's a problem. So can we treat tendon and ligament tears? I'm going to show you 2 examples of great kind of examples. This is a knee ACL tear. If you've got a partial thickness tear, definitely. If you've got a full thickness tear, in some cases, yes, we still can. So this is a 28-year-old man who he's a butcher. He had an ACL tear while playing recreational volleyball. We treated him with bone marrow stem cell treatments a couple of months after his injury. At 3 months, no pain, restarting dynamic exercise along with physical therapy. His imaging results are amazing. I'll show you that in a second. This picture on the right is under high-level X-ray guidance. You can see the needle going in. You can see where it's deep in the knee, and that's injecting into the ACL. You can really only do this kind of treatment under high-level X-ray guidance, cannot do this blindly. So this is an MRI before and after. The MRI on the left is pre-treatment. And what you see, it's hard for me to really, I don't have arrows I can put up right now, but essentially his ACL here is very hazy looking and has been described by the radiologist as likely a full thickness tear. The image on the right, you now have an ACL. This is 3 months after treatment. His ACL looks completely back to normal. So he's had not only a great functional outcome, pain outcome, his imaging outcome is great. This is now an example of someone who's got a rotator cuff tear. He's a 57-year-old man, full thickness rotator cuff tear. The ultrasound image on the left, I'm not sure if you can see my arrow here, but essentially the 2 pictures on the left show, a full thickness tear. He received his own bone marrow stem cells. We now have not only great pain relief, functional improvement, but if you can see his image on the right, you now have filling in of the tissue. So again, just a great outcome. And the next is interventional orthopedics, right? This is the idea of utilizing high-level image guidance to to inject your own cells. And you need to do that in order to get a good outcome. So the picture on the left, this is under ultrasound guidance, injecting into the rotator cuff tear. This tear is less than 1 millimeter by 1 millimeter. It's zoomed in here, but it's a very small tear. That needle injecting in there, if you do this without ultrasound guidance, this is just injecting a needle into a haystack, right? Like, or finding a needle in a haystack. And that it requires this kind of level of image guidance. On the right, now we're injecting into the shoulder joint. So we know we're in the shoulder joint because we see a little bit of contrast in the joint. We then inject into the labrum. That's a triangular structure that's lighting up. We know we're in that right spot because we can see that under high-level X-ray guidance and contrast. Again, these were X-ray images or imaging guidance for the patellar tendon under ultrasound guidance, and then for the ACL under X-ray guidance. Again, to do these procedures correctly, you have to have such a high level of image guidance. And if you do, you can get a great outcome. This is a 41-year-old man, ankle avascular necrosis, AVN. He's a chef on his feet for 13, 15 hours per day. It's incredible. He's developed some early arthritis, but he's also got basically the bone, avascular necrosis. He's got the bone in the ankle is now starting to die. So we treat him with his own bone marrow stem cells. He's several years out and he's doing great. What's amazing though is not only is he functionally doing well and pain is doing well, his pre-MRI image on the left, you see in the bone this white discoloration. That is basically avascular necrosis. The bone is starting to die. We're catching that at an early stage. The MRI image on the right, that white discoloration has disappeared, right? We've treated that avascular necrosis and he's doing fantastic. Regenerative medicine treatments offer safe and effective solutions for your pain. Let me just catch up on some questions here. So does it work for medium-sized rotator cuff tears? Yes, absolutely. The kind of rotator cuff tears that it's not going to work for is if the tendon is fully pulled apart and one side of the tendon is against one side of the bone and then the other side of the tendon is inches away from the other one. We can't treat that. But if it's at least 2 centimeters or less in tear, we can still treat that with great outcomes. So great question. Why are the treatments described here not the primary intervention for arthritis? They should be, right? Like it really should be the first treatment. I can tell you for myself, family or friends or patients, quite frankly, like if you have early arthritis or if you have a new onset injury for the knee, if you get better with physical therapy and you're doing great, no functional limitations, no instability, great, you're fine. But if you're not, and if you're still having pain, functional limitations at an early stage, I would recommend treating this at an early stage. Absolutely. Like that is the right way to treat this. You can still treat this at a later stage, but clearly you do better if you treat this at an earlier stage. Do we treat thumb joints? Yes. As a rheumatologist, I see a lot of hand issues. So we do treat a lot of thumb issues for sure. Somebody asked me what insurance do you take? For evaluations, we take pretty much all major insurances, commercial insurances and Medicare as well. And a couple of the local HMOs as well. Okay, somebody asking about their neck, about pain with looking down. Yes, it sounds like they do have a neck issue and they probably need to get that evaluated. Somebody asking about, will the presentation be available following today's talk? Absolutely, you'll get that link as well. You can also find that on our social media sites after we're done today. When we take the stem cells from the hip bone, does it damage a hip? No, it does not damage the hip. Number one, we do not take it from the hip. We take it from the iliac crest. That's the back of the pelvic bone. Your body will heal from that in less than a month. You will not, we take a safe amount out so that it is not causing anything like anemia or infection risk. We do this under just local anesthetic. If you need like a little bit of Valium, that's fine. Do not recommend total anesthesia for this. To be honest with you, as a professional, like as a physician, like if we do this enough where, You never want to say something is routine, but like we do this enough where we know how to keep people comfortable so that it's not too bad. What people tell us is that on average, the discomfort associated with this is roughly a 3 out of 10. All right, so it shouldn't be that bad. Do you do the initial necessary imaging in your office? It depends on which kind of imaging. If it's ultrasound imaging, we do. If it's an MRI imaging, we would refer you out. If it's X-ray imaging, we refer you out. But we do certainly do the ultrasound imaging in the office if needed. Okay, great. Let's keep on going. Thank you for the questions. Again, if you have any other questions as we're going along, you can always, or after we're done, you can always reach us at chicagoarthritis.com. So is this too good to be true? It's a great question. To begin with, there's evidence that goes back to the mid-1990s. Philip Hernigue is an orthopedic surgeon in France who's been utilizing this for knees and shoulders since that time. He has data that compares his patients that got bone marrow stem cells in one joint, let's say in one knee, and then replacement in the other knee. And he finds very comparable evidence of efficacy. With the preference of utilizing bone marrow because you can maintain your range of motion and you're not having to take the risk of surgery. The Regenerative Network has data that goes back to 2005. I have personal experience since 2008. I mentioned this before, but this is a rapidly developing field, but it's not new. I have colleagues, surgical colleagues who, let's say 10 years ago, would tell their patients they thought these treatments didn't work at all. In the last year or two, now they're telling patients they think it might work and they'll be able to help them out with these treatments, but they're not sure. You know, the nature of medicine is that if you're a specialist in something, you know the details and you know what's happening. If you're dabbling in it, if you're not a specialist in it, you don't know. You don't know what you don't know. And the field is changing, but the reality is that there's been data for over 2 decades now. So it's not new. There's definitely right and wrong ways to do this. Your expectations as a patient should be grounded in reality and in evidence-based medicine, all right? Like you should not have, this is not magic pixie dust. This is proper medicine and the results are reasonable and expected. Again, how long do results last? Philip Hernigue, Regenerative, they have long-term data on patients doing well for long-term. What I still tell patients is if you have a chronic condition, have conservative expectations. That means that you may need a repeat treatment at some point a few years after your initial treatment. If you've got moderate level knee arthritis and we're treating with platelets, we'll probably need to repeat platelets 2 to 5 years down the line. If you've got moderate to more advanced arthritis in the knee, we may need to repeat treatment at 5 years. Or you may need to get a platelet booster after 2 years, right? Like have conservative expectations. Even if the data looks very hopeful for longer than that kind of results, still think a little bit conservatively. The way that you'll kind of maintain your results is improve your biomechanics, use the appropriate joint supplements, do the right exercises. Again, understand repeating treatment is actually additive. You get a stair-step effect, meaning you're at a higher level, and then if you repeat it, you get an even higher level. And try to keep ideal body weight, especially for lower back and lower extremity issues. You can reduce your stress on those areas on a 4-to-1 basis, meaning if you lose 10 pounds, you're reducing the amount of stress on those joints by 40 pounds. In addition, improve your metabolic health and inflammation. Losing weight helps with that. That's key because inflammation is a key driver of a lot of joint issues, even in wear and tear arthritis. I believe in this so much that, we do have a physician-assisted weight loss program as well that we think is helpful for our patients with lower extremity arthritis and lower back issues as well. So in terms of cost, understand that while evaluation, imaging, follow-ups, rehab, bracing if needed are all covered by insurance, this is not routinely covered. The procedures are not routinely covered by insurance. The exceptions would be if your company already covers it. So regenixcorporate.com, you can go there to see if your company is covered. Roughly 3,000 private companies do have the Regenix procedures, these RegenMed procedures added as part of their benefits plan, in which case it's treated like regular insurance. Cost estimates if you're paying out of pocket in the United States, dextrose prolotherapy is about $750, platelet-rich plasma is about $2,500 plus to start, and using your own bone marrow stem cells about $7,000 plus. Keys to determine value, Are the physician and the clinic, are they regen med experts? Are you receiving a real stem cell treatment or something that's been mislabeled? Also understanding these are in-office procedures. You don't need to be in the hospital for this. You can avoid very expensive hospital surgery center fees if you do this in the outpatient setting. Again, in the outpatient setting, like it should be done in a appropriate setting, meaning it should be done in a place where they know what they're doing, right? And if they do it, it can be done safely that way. Again, just to kind of sum up what makes a regenerative medicine expert, it's a lot, but really it's experience, it's focus, and it's doing everything correctly. And if you do that appropriately, where it's not just something you're doing on the side gig, right? Like it should be what you're doing full time. You get the right results, you'll get the right physician and clinic to be doing this for you. So a little bit more about how we do things here at Chicago Arthritis and Regenerative Medicine. We're focused on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain, evaluating you looking for inflammation, instability, asymmetry, neuromuscular issues, trying to correct with low-risk interventions to begin with. If you have something that's appropriate that is not responding to low-risk interventions, we then talk about regenerative medicine treatment options, utilizing your own cells, the best, highest quality of prepping those kind of cells, a plan that's tailored specifically to you, not a one-size-fits-all plan, but a bespoke plan to you, and delivering cells using the highest level of image guidance, doing this in an experienced manner. We've been doing this since 2008. This is not new to us, doing this appropriately and safely for you. How do you get evaluated? In the chat section, listed a few different ways. You can go to chicagoarthritis.com. Our phone number is listed there if you're interested. You can email us, and you can even schedule directly on our online scheduling app as well. Wonderful. Let me just catch up on the last questions here. Great question. What are the risks associated with these treatments? So the risk associated with any of these treatments is similar to what you would have with any other injection. So if you get, let's say, a vaccine, a steroid injection, there's low risk, and same thing with these procedures, with infection risk, tissue damage, as well as no response. So how do we minimize those risks? We utilize standard of care when it comes to reducing the risk of bleeding as well as infection. We utilize image guidance to make sure we're hitting the right tissue, not the wrong tissue. That's very key. And then we pick the right candidates, meaning, are you a safe and appropriate candidate? For example, I will on occasion get patients who they're actively being treated for cancer and they're trying to get something else treated now. We have to talk to them about what is appropriate to utilize at that time to get the right result versus maybe what's going to be appropriate. What can we do right now? And then what can we do maybe after your cancer has been fully treated and you're in remission? Like there's a timing to this. Or there are times I'll get autoimmune patients that their condition is drastically active, where they have 20 plus joints that are active and they're asking, can we utilize Regen Med? And what I'll generally tell them is, look, you should really get your overall condition under control first. And now if there's a few extra joints that are still active after that's been under control, now let's talk about that. So there is a timing to these kind of things that's appropriate. From a risk standpoint, though, these are still considered relatively low risk. And we take all the proper precautions. Great. Somebody asking about bone on bone for the knee. They want to walk a block. That's very reasonable. We'd have to obviously evaluate your imaging, your issues, and then figure out if you're an appropriate candidate. But bone on bone arthritis, knee arthritis is something that we see commonly and is still very treatable. Somebody asked about supplements. We do have a list of supplements that we recommend that we do utilize. We generally will end up having people obtain that from a supplier that we trust. Great. These are all very good questions. We're coming to an end to our time today. Thank you, everyone, for your time. You will get a link, or you'll see on your social site, if you're watching this on one of our social sites, you'll see a link to watching this again. You'll be able to share that with friends, family, or colleagues if interested. And if we can be of additional assistance, please let us know. We're here to help. And until we connect again, have a good day and live well. Bye-bye.